we were met with the news that the systems, yet again, were changing, even before you were able to understand what exactly is going on. And so this is a little bit, foggy in my mind in terms of what exactly is happening. And so we said, okay, we must have a conversation today so we can understand. Does that mean 104 billion shillings went down the drain with the moving of this system? Or are we just saying we are moving from analog to digital? Is that what we're doing? Okay, what am I talking about? I'm talking about the health system that is SHA, that was SHA, that will forever be SHA. I don't know. Anyway, debt and digital NHIF. Is healthcare paying the price? Dr. Bill Morioki is here with us this morning and joins us in his capacity as the chairman KMPDU Nairobi and an NEC member. Very good morning to you, Dr.
Good morning, Do. Good morning, everyone.
Morning, hi.
Karibu. Thank you for being here this morning. Health economist and public policy expert Beatrice Kairu is also in the room with us this morning. Good morning, Beatrice.
Good morning.
Welcome.
Thank you.
Thank you for being here today. Let's try to open this up so that we have an understanding of what's going on. Before that, Dennis is going to share today's proverb. I can see Dr. already smiling. He'll tell you where it's from, and we'd love to hear your interpretation.
I have a question. People of Kenya called?
Kenyans.
Uganda?
Lesotho.
Basotho.
Well said. Well said. The one thing that stands out as well from Lesotho is the fact that it's one country in the world that is highest in terms of its elevation. It's 1,000 meters above sea level. If you want to enjoy snow, don't leave the continent, just go to Lesotho. They enjoy that because of their elevation. They have snow. They also have the Basotho blanket because it's cold. They have this blanket, not like a Masai Shuka, but now their version of Masai Shuka to be able to deal with the cold that is in the country. But the proverb we get from them says, even a small meal reaches the mouth. Even a small meal reaches the mouth. How would you interpret it? Ladies, go first.
What it means is that you should not despise something small. So it's like in our Kiswahili version, haba na haba hujaza kibaba, kidogo kidogo. So I would assume, I would interpret it as that small thing that we keep doing, eventually will amount to much. So a little will accumulate to something huge that we'll find it very difficult to actually solve.
Nice. Yeah. Doctor, how would you interpret it?
I think a bit similar. It might not be enough, but still, even it still gets to where it needs to get to. Yeah.
Well said. Well, your prayer sentence, Sana.
It will need to get where it needs to go, that's for sure. All right, so let's look into SHA this morning. There are a number of things, obviously, that Kenya does need a working health system. That goes without saying. It's a no-brainer. And that Kenya needs, and because it is kind of like a sacco where everybody puts a little bit into it and then allows you to then treat people. You pull the resources. That's one of the only ways that it can work. We've seen it work in different parts of the world, so it's clearly understood that if you're going to then be able to offer healthcare from a public perspective, that everybody's got to put a little bit into the basket, and also from the understanding that not everybody's going to be sick at the same time. So that's the model upon which this is formed. Now, in October 2 years ago, I believe the CS at that time then rolled out, because it was a different CS than what we currently have, rolled out the SHA system. And there was a lot of hullabaloo about what it was. 104 billion shillings was setting up this system. And it was supposed to be foolproof and ready to go and let's move. And everybody was told to register and do your business. Go down... Fast forward a couple of years, and for the last 7 days, there's the 7 days, I think now on 8 days, 9 days, there's been a glitch in the SHA system where your one-time password for you to then activate the process for you to get treatment in hospitals is not working. We were also told yesterday now that they were shifting from that system to another one. And this is now where confusion sets in because we're not quite sure what happens. Does that mean that you've abandoned the old system? Does it mean that now you've gone from analog to digital, where understanding that it was a digital system anyway? Dr. Morioki, help us out to understand what's going on right now. And we look into now the debt and other issues.
Yeah, so unfortunately, the issue of SHA has had lots of teething problems. Mm-hmm. In fact, if it was a child that was trying to teeth for this long, you'd be a worried parent. Mm-hmm. But what now we are facing essentially is probably like a slight change of direction.
Okay.
Because before, what used to happen is if you're a hospital and you see a patient and you have claims to put into to claim from SHA, there was a SHA portal. This is part of that expensive system. Mm-hmm. And you'd have to upload all the documents and put all those things there. And then now from there, SHA will follow up with your payments. Now, what SHA wants to migrate facilities to is a HMIS system, which is a hospital management system.
That was it, HMIS.
HMIS, yeah.
We knew it was a miss. We weren't quite sure which one.
Which we kind of miss.
Miss it was.
It's always a miss. No, this is just the H one. Okay. Yeah, so, and the idea of a HMIS, which is a health management information system, it's more than just a portal for putting in claims. It manages the entire hospital. Mm-hmm. So you can imagine as a hospital, beyond just claims, there's a system that manages the patients, who's where, what they've consumed, what they've ordered, what the doctor has ordered. So most hospitals have essentially a system. Others are manual still, but then most have digital. So now what SHA is essentially telling hospitals, you have to migrate to our system. So that then now when you see a patient in your facility, wherever it might be in Kenya, you see them using our system. So that then now eventually you don't need to do another whole claim process.
Okay.
But then if you've seen them through our system, we also have visibility into what you're doing. Mm-hmm. Yeah, which of course raises more questions.
But that's not a good thing, Dr. I mean, surely that would help in like paying off claims and things like this, isn't it?
Exactly. And that's the thinking behind it, that SHA is saying, instead of even doing double work where you see a patient using your system and then you have people in the claims department to now do the claims, just run the patient through our system, order the drugs through our system, the procedures, the treatment. We can see everything. Therefore, there's no redundancy. So on paper, it's good. But then, what I'll ask you maybe is, if you've run a hospital for 20 years, you probably have your own system. You probably have your own records. Number two, what happens to the ones that you finished claiming through the former portal? The ministry right now is saying, don't worry, as much as we're not using that, those claims will still be verified and everything. Number three, it also brings up issues of privacy.
Data privacy.
Because at the end of the day, one thing you can do is have a system for putting claims. But if you're running your entire hospital using a system that has a back-end access by the people at SHA, maybe my ex works at SHA and needs to know what is happening with me, can just check my records from there. So once you force hospitals to onboard onto a system that they themselves have not procured, they themselves do not know who else has access to, you open up another can of worms now, unfortunately.
I mean, as a health economist, I want to look at this a bit different. SHA is 104 billion shillings deep, you know. That's how much so far the country has spent. And for a system to be having these glitches and teething problems, as Dr. would call it, one asked the question, was implementation of SHA or SHIF, whichever way you want to look at it, flawed from the word go? Could it have been avoided if only due diligence went into the process of implementation, public participation of not only Wananchi, but also the hospitals who already have their systems, so that if there are any changes that needed, all these things we're talking about today would have been handled back then before the launch and implementation of the system? From an economist point of view.
Yeah. So it's by design. How SHA was designed is where the problem began. Remember how it was designed at first? It was supposed to be mandatory for every Kenyan citizen to contribute towards SHA. But remember, everyone has a right. You cannot make it mandatory. You have the right of choice. That's the privilege you get because of the Constitution. Number two, they expected the informal sector will come on board to actually contribute towards that SHA. But when you look at what is happening is that only around 890,000 informal sector are contributing towards SHA. Actually, NHIF by the time was transitioning now to SHA, 7.1 million Kenyans were contributing toward NHIF. Currently, as we speak, only 5 billion Kenyans are contributing to SHA. So SHA is still lagging behind. Why? Because when you look at how they introduced the 2.75 contributions, remember it is supposed to be an annual income to the ones who are in informal sector. Then, when you look at the informal sector, how many people have a stable income? Very few people. So the moment the people who have no stable income and you want them to pay contributions, it is not possible. So there is no sustainability. So you realize most of the Kenyans who are in the informal sector contributing towards SHA are those ones having a condition that should be treated. No one is sitting, in their sitting room and say, let me contribute in advance. Then those ones who are contributing consistently are those ones in the formal sector. But remember how it was structured is that every employer is going to contribute to the SHIF fund. But the burden of NHIF, that the 30 billion we say that NHIF was not able to pay providers. Remember, the greatest culprit was the government itself not remitting employer contributions to NHIF. So now in SHIF, there are also employers not contributing money to the same fund. Now, also how it has been structured, there is a portion of the SHA that is funded through the exchequer. So when it began, when SHA began, remember there was very minimal funds being allocated to it. Only that in the current budget for this year, somehow funds have increased, but not yet enough. So when you look at all those factors, then definitely it means the cash flow in of SHA and the healthcare cost growth are not much. There's a mismatch already. So that mismatch will already tell you there is a problem and it is not sustainable, because we have to look at the financial sustainability of that system. So the government, when they designed SHA, they did not first resolve how are we going to ensure consistent contribution by every Kenyan citizen. They should have first resolved that. Now, let me even poke a hole further. So when you have a country where this unemployment rate is so high, who is going to contribute to that fund? So our economic system, the government has not solved our economic system. We have not solved our political economy. There is no way you're going to force a Kenyan who has no income to contribute anything. So then they introduce, the worst of it all, they tell you, if you don't have an income, we are going to give you a loan. So fine, you'll take a loan because you're sick and you need the loan. But how will you ever repay that loan once you're well and you do not have an income? You see, already it is not making sense from the word go. And some of us, what we advocated for, why can't we tailor-make a healthcare financing system that suits our economy?
So the question is, if it is clear, even with NHIF that had 7.1 million people in the system contributing,
yes,
this is not just registered, contributing, who are giving something every month.
Yes.
Even with that, it was at a minimum. It was at the minimal that you needed to actually run a robust health system.
Yes.
So what would be so difficult? Because it is clear that people on their own, Daktari can tell us, the people who come to seek medical attention, it's at the place whereby you realize, oh snap, I'm going to need a major life intervention here, a medical intervention here to save my life. So you run around and you do the harambe, you do whatever, you get the money to come and do the procedure. But insurance is still in people's minds, because that's what this is. It's insurance. You pay now for possibility of a sickness in the future. So if it has proved so difficult over the last 30 years to actually get people into this habitual insurance payment, why not do it like you have the road maintenance levy fund, whereby you're not asking people, have you paid your road maintenance levy fund this year? No. It is removed when you buy fuel. And everything is moved by fuel. So you have seen that this thing is so important. Why not tailor it so that regardless of what happens, you will be able to treat the nation, because they're going to pay the tax for it anyway?
That was advocated for, but for us who are health economists, we recommended that. The government ignored us. Parliament ignored us. Because based on how our economic system is, we are an agricultural economy. So we depend on the rains. Remember, we don't even have dams that can do irrigation throughout the year.
They are coming.
Yeah, wametenga. Watakuja. You get. So whenever we say that we use sin tax, so if it's the sugar you're buying, a certain percentage of the tax on that sugar goes to healthcare. If it's the cigarette, because we have to look at those lifestyle or behavioral, or we call them behavior, that contribute to an increase in disease burden. So you tax them more. So that what happens is that people will not, engage in that bad behavior. For example, if you introduce high taxes on sugary foods, sodas and all that, very few people will consume it. So diabetics or lifestyle diseases due to high sugar levels will definitely go down. But in case you still consume those sugary foods, we set aside some amount of money or part of that tax charged on sugar to be set for healthcare to cover the cost.
But does it?
No.
Does the money that is actually coming from sin tax actually go to health?
No. That's the problem. So there's no dedicated percentage that goes to healthcare.
I mean, Dr. As we talk about the system right now, and clearly we've seen the loopholes that already exist with the HMIS. For me, the fundamental question is, already SHA as a SHIF as a fund has had problems before. With this new system, and that is being implemented, or rather has been put forth, has it been tested for us to look at would-be challenges and how they would be resolved? Or is it a question of, let's just bring in the new kid on the block and say we are fixing it? Because we could be fixing it but worsening it. Because one would say, if we already had used SHIF for 4 years now, right? Already people knew how to go about it, how to go around it, how to deal with the issues around it. All it needed is to just deal with it. Not teething, those are what? Even if it's teeth, those were molars. The molar problems, right? Like the grown teeth now needed to be dealt with for us to say the problems that were there have been removed. Now the system is working. With this DHMIS, has it been tried? You as doctors who are interacting with it, the hospitals that are dealing with it, have they tried it to look at pros and cons? Or is it just the new shiny kid with locks is now in?
Yeah, and I like the fact that you bring up that as a potential issue. That, fine, first of all, the diagnosis of the problem you want to solve is really not the fundamental problem here. Because the new system, fine, if you bring everybody into managing all their patients with your system, it reduces things like redundancy, it reduces things like maybe a bit of verification becomes easier, because catching fraudulent claims becomes a bit easier because you have a lot of visibility. But that's what you've chosen. You've actually decided to choose that's what you'll solve about SHIF. But then, as you point out, number one, you're also centralizing the possibility of failure. Because what you're basically telling a hospital before, you could run your system, but even if the SHA portal is down, you can still struggle with making claims, but you're still seeing patients. But now, if everybody goes onto this new system and runs the hospital with this system, what happens with the day that it goes down? So now you even have nationalized and centralized a potential point of failure. This system, secondly, who has been consulted about it? Like, do all hospitals run the same way? There's so much that goes into these things that you really feel are really a bit underthought. The goodwill, I always assume good faith with policy making people, but then there's just a bit of due diligence that you just need to do, because fine, the system might be good, but then as you bring out, if it fails, it means that day essentially no hospital in Kenya can function. It can't even dispense drugs, it can't even do stock taking, because the thing that was supposed to solve the verification of claims is now down for everyone. So such a thing is just a big risk. In fact, if you're doing risk management, that would be my first risk issue.
The matter of debts that's then owed to hospitals is an issue. But then you're kind of like stuck between a rock and a hard place, because then what do? The truth of the matter is that you may have a lot of people who are registered in the system, but you don't have enough people paying. And that's from my understanding, we don't expect that government is going to look for another option to get money to sort out this health system. Not at the moment. And so the 27 billion that's still unpaid to hospitals, county, and what looks like is possibly going to be yet another debt coming up, How do you reconcile that there's not enough money coming through? And actually, at this point, I find myself saying, so what do we expect SHA to do? Because it is an insurance system. That is how it is designed to work. So the debt is huge, but the burden to provide the healthcare is even larger. So what do you do with a huge debt, not enough people paying? It looks like it's going to be cyclical. And it will continue to be that way, is it?
Yeah, until the government deliberate decides to put more funding to SHA.
But they don't have it.
So when they budget, they're putting more funds to State House. Recently, we saw they set aside 45 billion to pay referral hospitals because they also drain. Remember, they're also part of the culprit of those not being paid by SHA. So either way, to get these people out of this debt system, the government has to make a tough decision. It cuts down on others' expenditure and focuses to clear this debt. Then going forth, resolve and say, if along down the line for so many years, contribution towards SHA has been very little progression, then it is not working. Remember, the system in its essence should actually have been designed in a way that it can actually accommodate each and every Kenyan citizen indirectly. Remember, you have asked how comes insurance in our Kenyan context has never been accepted. Remember, only 25% of Kenyan citizens are insured, both publicly and privately. So because every Kenyan citizen assumes insurance is a luxury. So even when I'm paying SHA, it's a luxury.
Until you get sick.
Until you get sick. So ours kind of behavioral or cultural. Remember, when you introduce a system, you must study the culture and the behavior of that community. So we are not like white people, whereby we are able to set aside funds ahead. We anticipate we can get sick. Remember our belief system as Africans. If I start believing I'm going to be sick in the future, it's a taboo. I'll bring it on myself. You get? So whenever you are telling people to plan to be sick, it is against the system. So definitely it will be an uphill task to ensure that these people come on board. So government has to shift and say, going forth, let's have a fully tax-funded public healthcare insurance system on the go. And we also need to separate between public facilities and private facilities. So that now, when you have a public-funded health insurance, then let it be used to uplift the public facilities. The moment you bring everyone on board, remember, private facilities, their aim is to make a profit. Unlike public facilities. Remember, the public facility, the land is owned by the people. The doctors working there are paid by the taxpayer. The building were built by the taxpayer. So the only return in investment is healthcare to the citizen. But for someone who is in a private hospital, every single service that they're offering, they have to make an extra coin out of it. So when you introduce a public funded insurance system to also cater for the private sector, then the funds will not be enough.
I mean, Doc, I want to ask a simple question when it comes to healthcare in the country, and even SHA as is, right? Have we politicized healthcare in the country so much that you're not having tough conversations? Why do I say that? We know that healthcare is not free. Somebody must pay for it, right? And in a system that the government has seen, it's an insurance where it's a portal where everybody needs to get in. At the end of the day, would-be registered members must chip in something in that portal for them to benefit. Because remember, if I don't get sick in 10 years, it's a good thing. But we've not told Mwananchi that the money that you're contributing is helping another Kenyan in Mombasa access these services. We are not having honest conversations about what SHA or SHIF is, what it wants to achieve, and how your contribution is changing the game. Because whilst you're being told 2.75% for those who are employed, those who are in the informal sector need to pay. But then again, you see, the political class will tell you, wewe ukienda, wewe enda utibiwe, uende nyumbani, mtu akikwambia ulipe, nipigie. But that is not in the policy document that has set up SHA. We are not having honest conversations because, case in point, I am Manuel. I can't go to a private insurance and say, unitibu kitumia that policy of that guy, because they'll tell you, you're not our member, you've not paid, you can't access services. Are we just playing politics with SHA that we're not dealing with the fundamental issues that do exist?
And I think at the heart of what is problematic here is what you're pointing out, that we are trying to politicize something that is very straightforward maths. It's what you can't fake around numbers. So the political class is looking for a very simple narrative that, since Ndu came into power, nowadays we go to hospital and we get treated for free.
Yeah.
Which is possible. But then now you have to come back and have an honest conversation with yourself and say, okay, how will we make it free?
Yes.
Now, what is currently happening is you're squeezing the middle. Number one, as much as someone went to hospital and got treated and went home, if you don't pay that hospital, the mwananchi and the hospital owner has two very different experiences about SHA. One feels SHA works, the other one feels like SHA doesn't work. Now, the other people in the middle is the healthcare providers. Because let me give you an example. If you got, unfortunately, into an accident and you broke your femur bone, your thigh bone, the package SHA offers is around 140,000. If you look at other insurance packages, for just the same procedure for fixing it with a nail is around 300,000. So what you're basically even telling that hospital is you figure yourself out with much less money for something that even other insurance providers tell you, okay, that will require a bit of imaging, a bit of this, a bit of drugs, a bit of... You can't do it with that kind of money. And in fact, even SHA nowadays becomes even a bit more absurd because, say, for example, the accident was so bad you broke both your femur bones. It won't accept the claim for both. It will just say, this is one person. You can't make this is a double claim. So they actually reject that claim. So what happens on the ground is you treat one,
you leave the other.
And then now, after some time, you treat the other. So you see, what you're trying to do, playing around with the psychology of someone getting free treatment somewhere, is you're trying to squeeze it out of the middle. Like the people in the middle are the people getting the hurt the most. The owners of the hospitals, the healthcare providers. Because remember, as a doctor, if I do that procedure on the broken thigh, and you claim it from SHA, I won't get paid until SHA pays the hospital. So if SHA doesn't pay the hospital, you're also not paying the doctor. And then now you start running into things of staff have not been paid, suppliers have not been paid. So who essentially here then is providing the free healthcare? It's not the government, it's the healthcare system. And that's why, to the topic of the day, the person paying the price is the healthcare system. And the problem with the healthcare system, it's not incentivized to continue paying your price for the government. There's nothing in it for them as well.
Okay.
That today, if the problems that do exist within SHA and the debt that exists today, if that is not sorted out, even with the new system, the problems still exist, meaning we've not really dealt with the root cause of the problem.
Exactly. In fact, what we're trying to do by changing systems is almost like saying, I don't have enough money to pay everyone in this room, but stop using M-Pesa now. Please go open Airtel Money. Let's start trying to see whether now with Airtel Money, it's fine. Maybe M-Pesa was a bit slow. There are issues around M-Pesa as well. And this has nothing to do with M-Pesa and Airtel. But fundamentally, that's not the issue here. So you'll get everybody to move to Airtel Money. But then if the money was never enough in the first place, you still run back to the same problem.
Indeed. From a practitioner's point of view, you handle the patients. What would it look like, Dr. Morioki, if you had a health system that worked optimally, whereby the funds that were necessary were available? What would that look like? A day coming into hospital at whatever level?
Yeah, I think for you to just imagine such a different future, you just need to go to a few countries that have done it and have done it well. I think fundamentally you just start with fixing the funding model. Because at the end of the day, healthcare costs money. There are people, there are drugs, there are machines. So once you make sure there's money, and you can get this money from different models, Ndu talked about scrap the whole membership thing, just come up with a tax and just, I don't know, fund it the way we fund schools, free primary education. Nobody is told, oh, you don't have a child, you don't pay, or all of us just contribute taxes and school is free. So you can play around with different models, put taxes in there, put personal contributions. You can even put even a bit of co-payment. Because remember the other thing with SHA, and that's back to your point about politicizing it, it's important for it to be said to be free. But you'll go to other places where there's a bit of a co-payment, which also contributes to the pool of money, because yes, the payment would have been 100,000, but you have to raise 5. So first, once you fix the funding model, then now after that, everything else is about, it will work seamlessly as long as now there is no interference with playing around with the money. So if something is costed correctly, someone comes to hospital, let them get whatever they need, let the hospital get compensated for what they have provided, and then the patient goes home. And you don't even need to go to an outside country. Think of a private hospital with a private insurer. That's what basically happens. You just walk in, scan, they confirm it's you, and you go get your service. You never even follow up after that. Like, you never even know when the insurance paid the hospital. And when you come back again, it's working as you left it. So if you can do that in a smaller kind of bubble, just fix the funding issue. Because fundamentally, and I remember when we were choosing courses back after high school, there was this course called actuarial science, and a lot of people used to say you have to be very bright to do it. I never used to understand what it was for. But this is essentially what we're talking about, like how much. Because, like, for example, SHA now, for a family and all the dependents and diet, you're given 3 major procedures. I think it's 2 major procedures and 3 minor procedures. So as I was giving an example, if I got into an accident and I broke both my femur bones, those 2 are already 2 for my family. Now, if my wife was in the same car or my children were in the same car, already our family is already done with the whole SHA pot. So the funding and the modeling around this issue is the root problem. Every other thing, the corruption, the systems, the digitization, now all those are just, you're trying to sugarcoat and trying to really paint over like a very rotten house.
I mean, you know, Dr. has mentioned something that I think we just want to talk about, right? In a model where a system is working well, corruption would not be a problem. Because then again, where corruption does not exist, Wananchi would see the need of paying because they know their money would go into the right use, right? That as well, in the messaging that we see that comes from government on what SHA ought to do, the politicization of the same, I feel like the entire communication of what SHA is, how it will benefit Wananchi is not there. So Wananchi is like, the hell? When I get sick, I'm gonna look for the 6,000 bob pay if I get it anyway, and I will pay because they do not see the need anyway. So let's talk about corruption that does exist. Let's talk about poor communication and even handling the funding mechanism, because one would say where we have 32 million people who are registered, if you came up with Lipa Polepole and make it easier for someone to be dropping in money, they're adding into that pool. But you're being told to pay annually. You know, where many do not have that. How do we fix these things, especially when you talk about corruption? Because we have ghost school, not ghost schools, that's to exist. Ghost hospitals and ghost patients, but they are paid. How do we deal with them? Because has even the new system addressed that?
No, the new system has not yet addressed that. Why? Because we already have 5,000 facilities using the HMIS. So when the CS and the CEO of SHA was talking about 3 months for people to transition, they were targeting the other 6,000 that have not yet transitioned. But be as it may, remember that to transition will cost money. So
again,
it will cost money because that facility has to acquire that HMIS. The only question is, for every policy change or for every policy being established, has it been budgeted for? So in Kenya, we have a way of introducing a policy, then we budget after Yeah. So instead of budgeting and then introducing a policy. So for example, if I was the one running government, I should have budgeted for the transition to the HMIS so that I can support those small clinics, I can support those hospitals or healthcare centers in the rural setup. Remember, they are the mostly affected. I would, give technical support, the training of the healthcare workers that will actually use that system. It will cost you money to train those healthcare workers on how to utilize that system. So whenever you don't put money aside to accomplish a certain task, then the implementation will be very, very messy. Now, to solve the funding problem that Dr. was talking about, there is no way you can bring money in so long as the Kenyan citizen do not have a job. So long as the unemployment rate will always be high, be assured we'll always have problems. And even if you introduce lipa pole pole, kama hakuna hiyo pole pole, hiyo kidogo kidogo, there will be no contribution. So I would insist, whoever will come into government, create jobs for Kenyans, they will have a purchasing power and they will purchase those premiums, or they will be able to contribute. Even if you introduce a tax, they will be able to contribute towards it. Because even if you introduce a sin tax, for example, let's say sugar, for example, if I don't have the purchasing power to buy that sugar, still you will not get anything to contribute towards that healthcare system. So we have to introduce that. Then also remember, so long as government does not have a social contract for any policy done publicly for the public, if there is no social contract between the citizens and the government, that thing will never work. So the social contract between the Kenyan citizens and SHA has never been good. So there is always mistrust. And the moment there is mistrust, it will be a struggle day in, day out. Even that lipa pole pole, even when you go preaching the gospel, there is still no trust. It will never come to fruition. So for the corruption, we need to see those ghost facilities, those people who have caused fraud. Have they been, put to jail? Have we seen people being fired and actually returning that money that has been taken away from that fund? Until we do that is when you will create that social contract again to come back between the Kenyan citizen and the people. But we need to have a president who will have political goodwill. Because without a political goodwill, nothing will ever work. As much as we say it, we don't politicize. But let me tell you, political goodwill goes a very long way. When you look at those countries we are talking about, that where it's a tax-funded public healthcare system, that it is working because there is goodwill. From the leadership all the way to the citizens, there is goodwill. But when you realize that your leaders are going to go to India, go to London for healthcare, why would the citizen trust it? If our own leaders don't trust our healthcare system, why would I also trust the healthcare system? So because of all those factors and issues, then we still have a very long way to go until we have the ideal healthcare system that Dr. was talking about.
Are people going untreated in the country at the moment who require medical care?
I think the answer to that will be yes. Because at the end of the day, for example, first of all, there are people who don't even have the money for the SHA payment. So there are those.
The 600 shillings, if it was in that band,
yes,
for example, or 720 per
Even
year.
300 shillings.
Yeah, 300 shillings.
And then there are those who are now insured by SHA. But then you go to a facility, and because the facility has not been compensated, they just say we are not accepting SHA patients. So you're essentially stuck. It's like paying for an insurance, and when you go to a hospital, they tell you, oh, we no longer take that insurance. So there's a lot of fall of people who can access services from SHA.
So we make the connection now, because a lot of times, I mean, here in this room, the things that we get to hear is that SHA is not working, SHA is not working, SHA is not working. And so now we can finally make the connection so that when you go to a medical facility and you're denied services, not because there is no hospital, not because there are no medical staff there, not because there's no medicine or equipment, but because this facility, for example, has gone unpaid.
Yes.
They will tell you, we cannot treat you under SHA.
Yes.
So is that person right then to say that SHA is not working?
Exactly.
Yes, they are.
And in fact, even like some of the doctors I represent, Nairobi County government, their healthcare insurance policy is by SHA. They used to be under private cover. I think it was Jubilee. They decided, let's try SHA to provide cover for our 20,000 members of staff. This week, you go to a hospital, SHA is accepting SHA. But then they haven't been paid for a while. Next week, when you come back, they have a policy out there, like no more SHA patients.
Yeah.
You go to Nairobi Hospital, same. Everybody same. And then now, when SHA compensates them a bit, then they can say, okay, fine, we can open our doors a bit more. So even the lack of reliability of cover for even our members, even for people who actually work and pay those, that's 2.75%, SHA is not working for them. Actually, the places that SHA is really working well, and we be honest with it, because a healthcare insurance provider has many aspects. Number one is collecting the money. Yeah. I don't think there's a Kenyan who should be deducted SHA who's not getting deducted. The other place that SHA is doing really well sometimes is getting people to get free cover. This is the normal Mwananchi sometimes who gets it. But the healthcare system itself, both as consumers and as providers, are the ones bearing the brunt of the weaknesses of SHA.
I'll give you an example. I come from Nyeri town constituency. And during the week, Monday to Friday, patients will be seen and SHA will cover. But when it comes to Saturday, they are told SHA is not working. They'll have to pay cash. Why? Because there's delayed payments to the healthcare providers. They have to look for a way and get some little cash to sort some of their few problems. Because by the time they wait for that SHA money to come, it may take a long period of time. And remember, these facilities have suppliers. Those suppliers are Kenyan citizens like you and me. And remember, if those healthcare facilities do not pay me money as a supplier, then I will also not contribute to SHA. You see, because that's where my income is coming from. So only recently that they have changed the system, but every mother walked into a healthcare center, they were first told to remove 200 shillings and then register for SHA. And then you can be seen by a doctor. But then when they go on a weekend, that is on a Saturday, they are told today, sorry, you have just to pay cash 100 shillings. There are those people, even that 100 shillings is difficult to come by. And definitely they will be denied access. So I'm just proving to you that it's true. That there are people who will literally not access any healthcare services because of how the system has been set. And remember now, healthcare providers will become creative. So they'll be saying maybe 3 days we use SHA and then 2 days we do cash, so that at least we'll be having some little money or some petty cash to keep us going by. But that is not how it was intended to be. So if only SHA can have prompt payment of those debt, SHA has way of ensuring that the fraud is minimized. They have a very good claims management, team to actually do that work and separate. Actually, what we had advocated for, the healthcare, the provider for insurance, that is SHA, should be separate from the person also doing claims. Because you cannot not be one and the same body.
Right.
You get those two should have actually been separated. But when we introduced that recommendation again, Parliament ignored us. Yeah.
So, Doc, we find ourselves, I think, we're in between a rock and a hard place. A new system is there already. Healthcare providers and hospitals are a little bit on the fence about it, because also on in terms of their data, on the fence about it. There hasn't been engagement or conversations on how this thing is going to be achieved. When you talk about universal health coverage for everybody, that is a fundamental right, should be affordable and accessible and of good quality. With all things existing, is it story, or is there any intention in actually offering this service?
No, I think as I said earlier, I always ascribe good faith. I think there are a lot of smart people working at the Ministry of Health, at the Digital Health Agency. There are lots of people who really want to do something. I think the problem is then they're caught between what we were saying, a bit of lack of political seriousness. I'll just call it seriousness because it's not difficult to understand what we're discussing. And then just being caught in between that and coming up with solutions to problems that they really can fix, because they can't fix the fundamental one. So, for example, when they're changing the system now, you can really see the thinking behind it. I can really picture the people saying, we need the hospital to be run through a system we have visibility through, because it helps with our verification, it helps with reducing fraudulent claims, it helps even with the other benefits. For example, like you can now, your records are here and you can go to another hospital and they know what you're treated for in the other hospital. But then on the other hand, the issue of data, like who owns this data? Who's going to keep a record of this data? Because if I went to MP Shah and I had a surgery on something very private, and that medical information leaks, then I have someone to hold accountable, MP Shah. But then now, if it's part of like a digital superhighway, as the government likes imagining it, then who do I hold accountable to? And how do you know the government won't even weaponize people's health records? Because health is a very personal thing. That's why you can see even a lot of leaders, when they get sick, they want to be treated abroad. Fundamentally, it's not even that the hospitals in Kenya are not good. It's even for the privacy aspect, because this is actually very useful information falling in the hands of people who are not of like the same persuasion of you. And I just wanted to even add something around the issue of what SHA is also doing to try and manage the issue of lacking enough money. Because it's one thing to not deny a claim, but then you can also elongate the process of paying someone so much that fundamentally just doesn't work. Because if you look at these deaths, I can see the numbers being put there. I think there should be a breakdown from the control of budget. Where is this money stuck? Because once you see a patient today, all patients are seen on credit, even private insurance. Like the insurance doesn't pay the hospital the same day. Before you leave the hospital, most hospitals have made the claim to SHA. Then you open a window of verification. Verification, they will try to look at, is the data correct? Is this person, was this actually done? And now, if you take months to do that process, are you taking months because you can't do it faster? Or is it you're taking months because you also don't want to get to a point where you now know you owe this institution?
Do you think SHA has the capacity to resolve all the claims, to verify all the claims that, say, are given to them on a daily basis?
That's a whole other Pandora's box.
They don't have cash flow.
Yeah, and then they also bring up issues of, we are trying to use a bit of AI. You can imagine basing payments based on, can AI match whether the name is the same here as the same here? And then there's a very high rate of claim rejection that somehow reeks of the intention to reduce the claims. Because when you make a claim to SHA and they find something like, for example, the names do not tally, there's a letter missing in one of the names, they reject the claim. What's your... Entirely. And entirely, there's no cause of recourse. And remember, that person came with a broken hand. You treated them weeks ago. It's taken weeks to get it even verified. Then you get, sorry, that has been rejected. Cause identity mismatch, for example. That person is out there using that hand now. There's no recourse you can get from SHA. The doctor, the implant, everything that was done was already done. Yeah. And then what you now see is hospitals now making claims departments. Almost people take personal responsibility. Because it's the same way in a restaurant where if you break a glass or something, we will charge you for that. Now hospitals are saying, if you make a mistake making this claim, because there's no cause for recourse, you'll take responsibility. And that makes you wonder, is it because you're trying to reduce the number of claims because you don't have enough money? Because an honest broker would tell you, we found that these are not matching, please go back to your records. Rectify and resubmit. But when you say, this is fraudulent, we're not paying, done.
You're sending a deeper message. And here we are thinking that we're just talking about the SHA debt, but it seems that there's a lot more, too many layers of all of this to then try and figure out. But it must be, and all of these things come together to form this perfect menu. How you then be able to serve up proper, medical care and keep the system in place. But it seems like this one needs to actually go back to the bottom, as Beatrice has told us this morning. Thank you both for being part of this conversation. We'll keep it at the front burner because it needs to be right there and we watch it so it doesn't boil over. Dr. Bill Morioki.
I think Dr. as well needs to tell us, what do you apply in your hair? But conversation for us.
Dr. Bill Morioki with the hair, chairman of the KMPDU Nairobi and a NEC member, as well as Beatrice Kairu, health economist and public policy expert. Thank you both for joining us this morning.
Thank you.
Asante, good morning.
This is the Situation Room, the only way to start your day.